And as folks continue to hop on, we just have one more minute before we start. But if you just joined, please do join the conversation in these two polls where we're asking for your opinion on the leading barrier for Black youth seeking mental health treatment. And also, if you're willing to share with us where your primary area of professional expertise is. Again, looks like there's quite a bit of diversity, so welcome all, and we will start in just one moment. All right. Well, thanks everyone for that initial input, and welcome to today's webinar, Preventing Suicide and Self-Harm Among Black Youth, which is sponsored by the Children's Safety Network at EDC. We're very glad you could join us today. My name is Ellie Stout, and I direct the National Suicide Prevention Resource Center here at EDC, and I am also a member of the Children's Safety Now Alliance, which helps to guide and support CSN's efforts. So I'm delighted to join you today as the moderator for this important webinar. CSN is funded by the Health Resources and Services Administration, and we have to clarify that nothing in this webinar represents the views, opinions, or policies of the federal government. Before I introduce our speakers, Kate Sinclair has a few technical announcements, so I'll hand it over to her.
All right, welcome everyone. So if you can hear me right now, you'll know that your audio is broadcast through your speakers. If you do experience any audio issues, and that'll be down to your internet connection right now, you can dial 866-835-7973, and please make sure to mute your computer speakers when you do so. You will be muted during this presentation. There are a whole lot of you, so we're going to ask you to put your questions throughout the presentation in the Q&A pod. It's just above Elizabeth, who's doing a great job right now. And so today's slides are at the top of your screen and for download throughout the webinar. And just to let you know, this session is being recorded and will be posted on CSN's website in the next week. Back to you, Ellie.
Great. Thank you, Kate. And now it's my pleasure to introduce our two presenters for today's webinar. Dr. Crystal Barksdale is the Chief of the Minority Mental Health Program for the Office for Disparities Research and Workforce Diversity at the National Institute of Mental Health, where she provides guidance and expertise related to minority mental health and mental health disparities. Prior to NIMH, Dr. Barksdale worked at my funder, the Substance Abuse and Mental Health Services Administration, or SAMHSA, where she led children's mental health, youth substance misuse, and mental health treatment initiatives. And she also has extensive experience working with healthcare organizations and other systems on health disparities, cultural and linguistic competency, and culturally appropriate mental health interventions for at-risk youth and their families. And Dr. Rhonda Boyd is an associate professor in the Department of Child and Adolescent Psychiatry and Behavioral Sciences at the Children's Hospital of Philadelphia, or CHOP, and the University of Pennsylvania Perelman School of Medicine. She is the Associate Director for CHOP's Child and Adolescent Mood Program and practices as a licensed psychologist specializing in evaluation and treatment of youth with depression. Dr. Boyd has served as a principal investigator and co-investigator on multiple federal grants, and she recently participated on the work group for the Congressional Black Caucus Emergency Task Force on Black Youth Suicide and Mental Health. I also wanted to welcome Elizabeth Clegg, who's joining us today to do signing for our webinar. So welcome to all of you. And just to let the participants know, we'll have both Dr. Barksdale and Dr. Boyd present, and we'll have Q&A after they've presented. But please, if you have questions that come to you during the presentation, go ahead and type them into the Q&A box, and we will address as many as we can during that Q&A period. So with that, I'm going to hand it over to Dr. Barksdale.
Great.
You have been muted.
Ellie, for that warm introduction and welcome. And thank you to the Children's Safety Network for the invitation and for inviting me to be here to talk about this very important topic. Can everyone hear me okay?
Yes.
Okay. All right. So I'm getting a little bit of feedback, but hopefully everyone can hear me okay. So I am going to talk with you this afternoon about suicide and suicidal behaviors in Black children and youth, and really from the perspective of just providing a little bit of context and background. And then I'm going to hand it over to my esteemed colleague, Rhonda, who's going to talk a little bit more about interventions and treatments. So I'm going to provide you with some context and talk a little bit about what we mean when we talk about suicide and suicidal behaviors. I'm going to talk, and then especially about risk and protective factors in this population. But first, I would be remiss if I didn't tell you about a little bit about my workplace, the National Institute of Mental Health, and our vision and mission. So this is our slide just capturing that. Our vision is we envision a world in which mental illnesses are prevented and cured. And our mission is really to transform the understanding and treatment of mental illnesses through basic and clinical research, paving the way for prevention, recovery, and cure. And so I say that because really NIMH is the lead federal agency for research on mental disorders. Our institute supports more than 3,000 research grants and contracts at universities and other institutions across the country and overseas. In addition, we support intramural research programs and researchers across the NIH campus. So let's talk a little bit more about suicide and suicidal behaviors and ideation and what we mean here. So I took these definitions from a contextual perspective from the CDC, the Center for Disease Control. And so first, when we talk about suicidal ideation, what we're talking about here is thinking about, considering, or planning suicide. And this can range from anywhere from fleeting thoughts to more persistent or chronic obsessions. And this is important because, especially when we'll talk more about the range of what we see with Black youth, with Black children and youth, some of what we find, some of what the research tells us is that Black children and youth may not actually ideate or experience ideation in some of the same ways and some of the same experiences that white youth or youth from other races and ethnicities do. So this kind of contextualization is really important. Next, we talk about suicide attempt, and this, again, from a definitional standpoint, is a non-fatal, self-directed, potentially injurious behavior, again, with the intent to die as a result of the behavior. And we note here that a suicide attempt might not result in injury. I don't have on here self-injurious behavior. I didn't define that here. That's kind of outside of the scope. But certainly we can talk about self-injurious behaviors in the context of suicide and suicidal ideation and problematic behaviors among youth. But here, with regards to suicide attempt, what we're talking about is a behavior with the intent to die as a result of the behavior. But a suicide attempt might not result in injury. And then finally, a suicide, here is a death caused by self-directed injurious behavior with intent to die as a result of the behavior. So now that we have kind of established that context, let's talk a little bit about kind of Black youth suicide and suicide ideation and behaviors. And before I present you with some statistics about this, I'm interested in what you think, and I want to get a grounding for what you think. So here we have a poll. Oh, good. So I think you can see these two polls here. As of 2018, oh great, as of 2018, suicide is the blank leading cause of death for Black children ages 10 to 14. So we have two questions here. One for youth 10 to 14, excuse me, and the other for the second age group, 15 to 19. So for the crowd, what do you think? As of 2018, what do the statistics say? What is the leading cause of death for these? Where does suicide rank for Black youth from ages 10 to 14 and for ages 15 to 19? I'm seeing a lot of votes coming through. Excellent, okay. The numbers are tallying up. Okay, we'll give it a few more seconds. Looks like the numbers are kind of converging for the 10 to 14-year-olds in terms of the second leading cause of death, and for the 15 to 19-year-olds, the second cause of death. Okay. All right, let's see. All right, let's see. Great. So according to the most recent data that we have available, as of 2018, suicide is now the second leading cause of death among 10 to 14-year-old Black children and adolescents. So for the majority of you that voted for that, you're correct. It is the second leading cause of death as of our most recent data in 2018. And it remains the third leading cause of death among 15 to 19-year-old Black adolescents. And of note, it has been the third leading cause of death for 15 to 19-year-old Black adolescents for the past decade. Here, this slide, I show you the trends. And we are really interested in the trends because what we see is an increasing trend among Black youth in terms of suicide rates over the past 17 years. And we've broken it out both by gender, but also by in total. And so you can see both from males and females, but also total, the trends are increasing, and especially among males, among Black males. While the suicide rate in particular for young Black males is over 3 times higher than young Black females, again, the rates for both males and females have increased over the past 17 years. And so recent studies on Black children have found, for example, that Black children under 13 years old, when we start to really parse out some of this data and really try to get a handle on what's happening, some of the studies have suggested that children under 13 years old are 2 times as likely to die by suicide compared to their white peers. Black males, ages 5 to 11, are more likely to die by suicide compared to their white peers. And again, the suicide death rate among Black youth has been increasing faster than other racial and ethnic groups. So given some of these findings, there's been increased attention to Black youth suicide. And thanks in part to Congresswoman Bonnie Watson-Coleman, who we heard in the introduction, convened a congressional hearing to discuss mental health solutions to address these increasing rates of suicide among Black youth. An outcome of that hearing was the establishment of this emergency task force on Black youth suicide and mental health, with Representative Watson-Coleman serving as its chair, and my colleague and co-presenter serving as one of the members. From the task force and the subsequent working group came the task force report entitled Ring the Alarm, the Crisis of Black Youth Suicide in America. Many of the findings that I have shared and will continue to share throughout this presentation are referenced in the task force report, and Dr. Boyd will reference the report during her presentation as well. It's an invaluable resource, both in terms of understanding the data, but also understanding the scope of the problem and understanding some of the solutions. So some other data just to, again, further contextualize and understand this problem. Now turning more not in terms of suicides, but in terms of some of the suicide ideation and behaviors. Between 1991 and 2017, suicide attempts rose 73% among Black adolescent girls and boys. This finding is significant because what we understand, again, is that it's not so much ideation, it's attempts that have risen over time. And in fact, significant injury has increased, especially among Black adolescent boys. In 2019, again, some of the most recent data that we are that's available to us has suggested that the prevalence of suicide attempts was higher among Black high school students compared to white and Hispanic high school students. And again, this is using youth risk behavior surveillance data. And I'll talk later in a little bit about some of the data sources that are available to help us understand the nature of the problem. So just very quickly, I do want to talk about understanding the risk and protective factors associated with suicide and suicide ideation and behaviors among Black youth. Here I present the social ecological model of suicide prevention. Again, the CDC has provided a valuable guidance in terms of a social ecological model that really has been used widely in terms of prevention, in terms of helping us understand risk and protection for a number of different health and diseases. And this model in particular is useful to understand suicide. Some of the benefits, this is a four-tier model, a four-tier framework for organizing risk and protective factors, and it then informs corresponding prevention strategies. So from the macro to the micro levels, the four different strata or the four different levels, as you can see here, are the societal, the community, the relational, and then the individual levels. So when we talk about societal levels or societal factors, that concerns larger scale issues such as social and cultural norms, policies, and other kinds of guiding rules or laws. Community level influences are those that are circumscribed to maybe a certain region or neighborhood, things like schools and workplaces, and even healthcare providers. Relational factors are those such as direct person-to-person interactions, such as social support, peers, and family. And then finally, at the individual level, those are person characteristics, such as demographic factors and attitudes, health conditions. This multi-level framework is especially helpful and beneficial when we consider and are trying to understand risk and protective factors for a public health issue such as suicide. for a number of reasons as I've outlined here. But I think most importantly, it provides us with a nuanced way of understanding how these different levels of factors can interact with one another to not only predict a behavior, predict the particular behavior, in this case suicide or suicidal ideation and behaviors, but it also helps us frame and can help us develop interventions and prevention programs more effectively. So I think that it's a really useful way of understanding and kind of articulating and understanding, well, what are the different levels of risk that we should be aware of. So these two slides, again, I won't go into too much detail, but I think depict the different levels and help us kind of understand how the different levels of risk factors are applicable for Black youth. Many of these risk factors that are listed here have been examined and researched widely and are applicable for youth from all racial and ethnic groups, including factors from a societal level such as economic downturn, stigma, and poverty, from the community level, exposure to community violence, from the interpersonal level, issues such as family violence, social isolation, and then from the individual level, exposure to adverse childhood experiences, LGBTQ identity, bullying and victimization, and psychiatric disorder. These are pretty well-researched risk factors, again, that are applicable not only to Black youth, but also to other youth. However, there are factors that are unique to Black youth that are culturally nuanced that require not only additional study, but additional understanding. And then there are risk factors for which we're really not sure and unclear. For example, there's stigma and the impact of stigma, both double stigma, so racial stigma, but also the stigma of mental health. And so how does that impact a Black child or a Black adolescent? And then how does that play out in terms of a Black child suicide risk? There's economic downturn, which we know, economic downturn and or poverty, which we know may have disproportionately affecting Black youth and Black families. There's systemic racism, which is listed here, and discrimination. Again, that uniquely affects Black children and Black youth. And so, again, there are certain factors that are listed here, and again, some that are not known or some that we just don't have enough research to fully kind of comprehend and understand in terms of their effects on Black youth. Psychiatric disorder is one in particular that we know there's evidence that disorders may not manifest in the same way among Black youth who are suicidal, or certain disorders may confer greater risk. There's also the issue of biases in terms of assessment or diagnosis or diagnoses. So again, there are certain issues with regards to risk factors that we have to more fully understand in terms of how they confer risk. And then lastly, just very quickly, I'll turn to protective factors and make the same point that, again, while we know some about some of the risk protective factors, and again, at these multiple levels, we do need to know there's more research needed and required to kind of fully understand the culturally relevant and salient nature of the protective risk factors, certainly for Black youth. Again, there's evidence for the role of religious involvement, religious engagement among Black youth, positive self-esteem, and perceived social support. However, again, more research is needed to kind of understand some of the role of other factors. So I'll end by just quickly talking about some of the next steps and then turn it over to Rhonda what we need in terms of where to go is improving data collection. Overall, there are gaps in our epidemiological data. We have questions about the underestimation of the data that we have. We have data, but we do need to have better data collection available. And so that's always going to be an issue. It's going to be a concern. We need better data and better representative data to be collected on Black children and youth. We also need to improve the ability to identify Black children and youth children and youth who are at risk for completing suicide and who are at risk for engaging in suicidal ideation and behaviors. So that comes again in the form of research and also in the form of better risk detection and risk management tools. And then we also need more research and information on the best targets for preventing suicide among Black children and youth, and to ensure that the approaches are both developmentally and culturally appropriate. So where can you go? Well, there are some research opportunities, and IMH does have a notice of special interest for those who are engaged in research that we do have out right now. And then you can also sign up for NIH guide notices. And then finally, as I mentioned earlier, we do have data sources available that, again, although there's some limitations, these are widely used. And so they're out there and available for people to use in their research. And so with that, please enter your questions into the Q&A pod, and I will turn it over to my esteemed colleague, Dr. Boyd.
Thank you, Dr. Barksdale, for that enlightening presentation and providing the foundation for the work that I'll be talking about. So I will kind of further Dr. Barksdale's presentation, and I will be talking about treatment engagement, screening, interventions, and also ending with resources. Much of this work that I'm talking about comes from the Congressional Black Caucus report. And so let's start. So one of the things when we talk about treatment utilization, there's been clear disparities that have been evident for Black youth. In particular, Black youth are less likely to receive outpatient treatment. They also are less likely to receive outpatient treatment even after having a suicide attempt, which I think is really important to note. And also, Black youth are more likely to be referred to inpatient services or often pushed into the juvenile justice system. And this is what we call the school-to-prison pipeline. And so instead of getting mental health treatment, many times Black youth go into juvenile delinquent or the prison system, and that sets them up for having a life involvement with criminal justice. I'm going to present, I will present a couple of studies that kind of illustrate some of the complexity of understanding treatment utilization. This is part of a study that was looked at youth between the ages of 5 to 17 in a Medicaid sample, and they looked at how much money was spent for youth across race, psychiatric disorder, and service use. Their interest mostly was to look at in-school services, but they also looked at outpatient mental health services. And what you see is that overall, there's pretty similarity for Black youth with white youth. One of the things that stood out is that for ADHD, so you see down here with ADHD, Black youth were more likely to have money spent for ADHD, which stands out. Why is that the case? Also, another disparity that you see is with autism. There's a lot of services for autism for Black youth. And so one of the things, it's not always set aside that there's differences, lower utilization. One of the things this is emphasizing is that actually working in school systems may actually be more helpful for Black youth, and that they may get the services they need. I'm going to also show you one of the findings that I mentioned earlier. This is a study looking at youth who reported suicidal ideation or an attempt within the last year. And as you see, the youth, Black and Latinx youth who had a suicide attempt was less likely than white youth to actually get any services used. And that is important. They also in this study looked at the number of psychiatric symptoms. And actually psychiatric symptoms number did not predict mental health service utilization for Black youth, although it did for white youth. This other study also looked at mental health visits through a national data survey. And I'm going to give you the bottom line of it, and I know there's a lot of information. One of the interesting piece about this is that they looked at different types of providers. And overall, Black youth received less mental health treatment compared to white youth. This also was found with Latinx populations also, and this crossed both children and young adults. One of the things that this did not occur for inpatient stays. As you see, they were more similar, or emergency rooms. And so part of it is that it fits with Black youth are using emergency rooms for services, which is not probably the most appropriate place to go. It will be better for them to receive treatment in outpatient settings so that they won't have to go to emergency rooms or inpatient stays. So this disparity is complex, and we need to spend more time understanding what all of this means. I want to talk a little bit about a conceptual model that was presented by the William T. Grant Foundation about looking at child mental health disparities. This looks at disparities both in disorder persistence, severity, but also barriers to treatment. And it is very complex, and it captures some of the things that Dr. Barksdale had talked about. There are protective factors. Particularly, they noted there's socioeconomic status, issues that come up that may impact disorder as well as barriers to treatment, and childhood adversity also impact these disparities. And family structure, neighborhood risk and protective factors. Dr. Barksdale talked about there are issues with community violence, maybe overcrowded, impoverished neighborhoods that disproportionately impact Black youth, which impact disparities in their psychiatric presentation, but also whether they receive treatment. And as we know, there are policies that are set in place that make it more challenging for Black youth to also get treatment. I want to talk about, I will go back. In the beginning, you all completed a poll, and it looked like mistrust, when we talked about treatment barriers, that mistrust as well as stigma were highly identified. There are a host of barriers that exist for Black youth getting treatment. But there are also limited community resources that in neighborhoods which are more likely to be Black, there's not as many mental health treatment. Also, they may have physically incapable of getting to these services. They may not be convenient on public transportation lines. And this comes up where economic issues may come up. There's insurance issues. There's treatment costs that oftentimes with insurance there's still copays. And as we say, income disproportionately impact African Americans in that they make less money in certain cases based on the structural inequities that are set up in the United States. And so these issues come into play. But there's also many times inappropriate treatment referrals. As we mentioned, some kids go into the juvenile justice system for the same behavior in which a white child may go into mental health treatment. And there may be limited information known about mental health treatment. So there needs to be sort of psychoeducation and understanding of what it means to get mental health treatment. And also there's misdiagnosis, that oftentimes there are points where African American symptom presentation may be seen as something else. There's substantial research showing that African Americans are more likely to be diagnosed with psychotic disorders. And so that sets up things where it may be another disorder, but they are diagnosed with psychosis. And so these are the things that we have to take into account. One of the things about looking at this, I recently saw a review done for Black youth in Canada, and they found actually some of the same treatment barriers, which was interesting because they have universal health care. So it's not necessarily about our insurance system or our health care system per se. There are more intrinsic issues going on that creates barriers for Black youth. But also there's facilitators, and I think that's important to note. There are things that help Black youth getting into treatment, and also many times severity of children's mental health. So when parents recognize that their child is exhibiting significant symptoms, as well as the school system, they're more likely to get treatment. And also caregivers' experience, so having their caregivers knowledgeable about mental health, they may have had their own mental health treatment, they are more likely to seek treatment. And we also therapeutic factors that go into play, that treatments are effective. No one wants to come to treatment and it's not working, they give up. Also that therapeutic rapport and trust, and that's where that mistrust come in, building that relationship. So it's important to spend that time working with Black youth to make sure there's a connection and that they're getting treatments that actually work. There's evidence to suggest that Black youth do not get empirically supported interventions, and so if it's not working, we can't expect people to stay in treatment. Also, religion and spirituality, having been involved in religious communities that support mental health treatment has been helpful, and also referrals by parents and gatekeepers. Parents are the ones who typically bring their children to mental health treatment, but also important gatekeepers, the school counselor, someone else in the community that may say, you know, I think something's going on. And if they're trusted, families are more likely to go and seek treatment. And also location. Actually being in urban areas, you're more likely to go to treatment than in rural. And that's probably an issue with being able to get more ease to the mental health treatment center. So what I want to talk about is the variability and intersectionality among Black youth. We talk about Black youth, but many times people have this assumption that there's a homogeny among Black youth, and there's a huge variability. Black youth vary in their socioeconomic status, their religion, where they live, even their ethnicity, their Black Latinx people, their immigration history. They may come from the Caribbean islands, or did their family come from countries in Africa. There's also gender differences. Sexuality needs to be considered, and schooling. What types of school? All these come into play and interact. So we cannot assume that once a Black youth is sitting in front of us, that they will be similar to another Black youth sitting in front of us. And we need to gather this information to be able to understand what are the factors impacting that particular youth. Next, we have a poll. So, which has been recommended for universal screening for youth? So we have suicidal thoughts, depression symptoms, or both. So people are putting them in. It looks like both is leading at this point. Okay, it looks like people are saying that both are recommended. Okay, we can move on. So I'm going to talk about screening next. And so as you see, the U.S. Preventive Services Task Force currently does not recommend that there's not sufficient evidence to recommend universal screening for suicide risk of adolescents. So both cannot be the case. So that is based on evidence that screening will produce better outcomes for youth, and there is not a current evidence to suggest that. And so this is an issue, and if any of you are out there in your clinic screening, gathering data is also important in writing it up because they're looking at what data is available. One of the things is that this becomes an issue because parents are typically not aware of children's suicidal ideation. And this is a study that I did with colleagues at CHOP and Penn. And as you see, we saw that when thoughts of killing self and thoughts of death, that most parents were not aware that their youth had these symptoms. And so that causes us a dilemma. In particular in this study, we found that people who came from a racial ethnic background, parents were more likely than white parents to be unaware of their youth having suicidal ideation. And this is important because parents are the ones who typically bring the kids into mental health treatment. I want to talk about ways in which we can screen. At the Children's Hospital of Philadelphia, we have a clinical pathway for assessing and treatment of suicide risk. And as you see, we have screening items. So for every visit, our initial visit, as well as every behavioral health visit, we ask kids about their suicidal risk, thoughts about suicidal ideation and behavior, and also there's questions about using the Columbia Suicide Severity Rating Scale, which can be utilized. Currently, there's not a lot of evidence saying what works for black youth, but I think standardizing it makes it simple so that we won't take assumptions that black youth aren't at risk. So next I want to talk about a study that was done in a primary care setting. This group of researchers actually standardized screening. So they gave pediatricians 2 items to ask at every visit, whether the kid had wishes for death and whether they had thoughts of killing themselves, and then there were follow-up questions. Doing the training, identifying the questions, actually, as you can see, actually showed an increase in identification of the youth across 3 clinics. So it increased, and their odds ratios were increased. So this is important. If you set procedures in which you identify and screen to identify all youth, you can increase the identification. And I think this is helpful because I think there's some assumption that black youth are not having suicidal thoughts and behaviors, and so if we standardize them, I'm hoping that we will be able to identify these youth so they won't end up having suicide completion. Next, I want to talk about depression screening. So as we talked about, depression screening has been recommended. American Academy of Pediatrics recommended universal screening for depression for youth 12 and older. And so oftentimes in depression screening measures, there's an item that assesses for suicidal ideation. So we think this may be an opportunity in which we can identify youth who may be presenting with suicidal ideation in the depression screening. Next, I'm going to talk about interventions. This table has a lot of information, but the bottom line is they did a review looking more specifically at studies that had large populations of black youth, and actually there are some studies that have shown to be promising that reduce suicidal ideation, attachment-based family therapy, as well as multi-systemic therapy and a good behavior game, but there's currently not enough evidence. There was a review of looking at interventions, psychosocial interventions, and the only well-established therapy for black youth is multi-systemic therapy for behavior problems. And the probably effective are peer-resilient treatment for traumatic stress and cognitive behavior therapy for disruptive behaviors. all these interventions that shown to be effective, all were adapted and culturally for their population. So I think that's important to note. So we have another poll. We have to do it quickly. We're running low on time. So are there depressions well set for Black youth? No. Yes, that is correct. Okay, I will move on. We can move over for the poll. And so although CBT, individual and group, and interpersonal psychotherapy are well established for adolescents, the evidence base is lacking for Black youth. And there have been no randomized clinical trials for any racial ethnic group for bipolar disorder. So when we think about cultural competence, this comes from the American Academy Association for Child and Adolescent Psychiatry, and they identify things that may be important, really taking into cultural differences when we provide services, the expressions of distress, symptomatic presentation, it may differ, particularly for Black youth. An example is that irritability is a sign of depression, anxiety, post-traumatic stress disorder. However, when Black youth are irritable, that's seen as aggressive, and that could be misinterpreted by a provider. Also, really assessing for trauma, loss, community violence, racism, discrimination, with the child as well as the family, also including key family members in assessment and treatment, whether grandmother may be involved or aunt and uncle may be involved in the child's life, and making sure we gather that information. And we also want to make sure we identify cultural strength and incorporate them into treatment. And then there's system-level actions. There's mental health first aid, in which we train people to be able to identify symptoms in all youth and be able to talk with them about it. And this is important so that we all become gatekeepers, the coaches, the teachers, people in extracurricular activities, so that this is a community action. And also, it's very important to reverse the discrimination and biases that is inherent in the mental health system. And there's currently been a lot of anti-racism discussions upon organizations, but we need to make that into action so that we know that Black youth are getting the type of treatment that they need and that they're not barriers set up in the system that prevents them from coming. So some of the recommendations from our report is that we recommended demonstration projects in order to advance what are the best and promising practices. We also talked about developing a screening tool for Black youth to identify ideation behaviors as well as self-harm, and on a protocol on how to connect and treat Black youth, because I think people don't know, and if we set up sort of guidelines, that may be helpful. Also, we recommended a certification program for training people into the needs of Black youth and how to address them. And so we're hoping with some supports of some of the federal governments that some of these things will come into fruition. I want to end on the resources. So this is the Congressional Black Caucus Emergency Task Force website, and it is available, and it has the report as well as resources. Also, I want to point out the Youth Suicide Research Consortium is a group of researchers focusing on diverse youth and suicide, and so these researchers are trying to do the work that is missing, that we're saying are these gaps. So you can check out their website, and then these additional resources, these are a few places, resources recommended in the Congressional Black Caucus report, but there's more on their website that lists a whole bunch of resources that you can utilize. And then I want to also emphasize professional organizations. As you all presented in the poll in the beginning, you come from a lot of different subspecialties, and I think it's important to look at the organizations, professional organizations you are part of, and see what type of resources they have that focus on Black youth and learn about them. this morning I woke up and I saw that an organization that I belong to, the Society for Research and Child Development, actually just put out a policy brief, talking about Black youth, as well as they had it actually for other racially ethnic groups, and talked about the effect of COVID, racism on these youth and how it affects their educational outcomes. So I think there are resources out there that you can pull together so that you can gather information that be able to improve your practice and your care. And hopefully, as the research comes along, we will catch up and be able to have some more evidence base for providing care for Black youth. Thank you.
Wow, thank you so much. So much wonderful information from both of our presenters today, and it's a lot to absorb. So thank you, first of all, for the excellent presentations. There's so much information and a lot for us all to think about, I know. So we are now opening the floor for questions. The arrow is sort of on my screen a little below the Q&A pod there, but hopefully you all have found it. And in fact, many participants were submitting questions throughout the presentation, so I've been trying to keep track and scroll through. I think the place I wanted to start for both of you really is a question that came in early on, which is, how is Congress planning on using this document, the report that we've mentioned today, and are there ways that we, the participants here, can help with dissemination or raising awareness, because clearly this is an important issue that needs to be addressed. So I'll start with that. I don't know which of you want to start.
I'll start. This is Rhonda Boyd. One of the things is Representative Coleman Watson actually, and members of the Congressional Black Caucus task force put a bill together about mental health equity. And in that bill, they outlined some of the recommendations about increasing access to school-based mental health, trying to reduce the disparities that exist in the current mental health system, actually increasing money to increase fellowships, to increase the pipeline so that we have more Black providers providing care. And so I saw yesterday that it passed a committee in the House of Representatives, but as you know, this is a long haul with things becoming a bill to a law, but encouraging that, talking to your congressional people about passing this bill and keeping it on your mind. It's on the website that I showed. You can find out more information about the bill. And Crystal, you want to talk about what NIMH is doing?
Yeah, I mean, I think we're talking. We're talking with Representative Watson Coleman and talking with members of the task force, and certainly about research and ways to understand and support research and trying to understand how we can support the research. I mean, I think it's obviously an important topic, and so I think the federal agencies are aware. And so we did, in April, a webinar on this same topic. And again, the NOCI that I mentioned is an effort, again, to support research around Black youth suicide. So I think it's something that is on our radar in terms of finding opportunities to support research.
Great, thank you. There have been a couple of questions about geographic diversity. So, Crystal, are there differences in terms of regions of the U.S. Where Black youth suicide might be higher or lower? Are you seeing an urban-rural disparity, or does the data tell you that?
That's an excellent question. I am not aware of that data in terms of breakdowns in terms of rural and urban, but and race, so the intersection of rural, urban, and race. However, I wouldn't be surprised, and I know that there is certainly individuals in rural areas. There's a very high risk, that's also a very high risk population with regard to suicide. So it would not surprise me. But with regard to kind of the intersection of race and ethnicity and geography, I don't know the data off the top of my head, but I do know that individuals in rural settings are certainly at high risk for suicide. I mean, some of the highest risk for suicide, and that's certainly an area in which we're also paying attention and trying to understand risk factors. And it also represents a challenge because there are also unique cultural issues and cultural nuances to understand from a rural perspective as well. So to Rhonda's point about kind of the intersection and really understanding the homogeny among populations, it's really critical because that's also important. Black youth who are in rural settings are certainly have very unique characteristics and unique demands and unique needs that Black youth in urban settings do not have. And so it's something that I think that obviously we need to understand and attend to. So it's an excellent point. I don't have the numbers. So the smaller you go in terms of parsing it down, it becomes a bit more difficult to know the exact numbers and get that data. But that's also why we need more data.
Absolutely, that makes sense. So many questions coming in. This one, I think, is for both of you to some extent, if both of you want to weigh in, but our participants saying a lot of research ends up focusing on intra or individual factors, so psychological and mental health factors that predict suicide. Is there research going on that you know of to explore some of those higher levels of the social ecological model that seem to be so important and are impacting suicides in Black youth?
That's a good question. From my knowledge, no. And we're trying to push because, again, it's also an issue of understanding the impact on disparities as well. And certainly we're trying to, I think, encourage more multidimensional research. And by that, I mean kind of multi-level, multidimensional research. So kind of exploring and encouraging research that does explore kind of the intersection of how those multiple levels interact and therefore impact risk and impact suicide and suicidal behaviors. But there's some. I would say it's emerging. I don't know any off the top of my head, and I think again some of it is growing, and there's certainly some that looks at more systems. So some of the work that maybe looks at more systems oriented, but it's still a lot of it still does come down to looking at kind of psychiatric risk and kind of the prediction of suicide based on some of those individual level characteristics. Rhonda, what about you? What is your perception?
Yeah, I would agree. I mean, the levels that we may get to is looking at family level variables as well as school level variables that people are starting to look at as, risk and protective factors for youth, but we haven't gotten sort of further up the ecological model.
Right.
Okay, great, thank you. And I'm so sorry, our time is running so short. Last question I wanted to ask you, Rhonda. There are a number of questions coming in about this intersectionality that you raised. So LGBTQ, Black youth, youth who are identified as American Indian, who are also Black, or of sort of both African and Native descent. So how, in terms of prevention, assessment, intervention, treatment, are there ways in which you've brought that into some of your work, the intersectionality?
I mean, part of what I think it is important, and I think as Crystal mentioned, sort of the research is difficult because of the numbers, but in a way, in our research that we do in our clinic, we ask a really extensive battery of assessing race and ethnicity, even from the parent, what languages are spoken in the home. We actually end up having a lot of kids who are multiracial in our group. And I think people haven't asked that before, and I think because people are having these multiple identities, and I think America is getting more diverse, and so we have to ask these questions. We also ask about gender identity as well as sexual identity and have a measure for that so that the kids can ask. And so I think that's part of how we do a cultural formulation. We take all that in account because we know that these kids may be at higher risk, especially as when you think about adolescents, they're already trying to figure out their identity. And so if they're dealing with maybe discrimination based on because of their sexuality or their gender identity, as well as if they're multiple race, they trying to struggle about where they belong, and these issues could put them at more risk for suicide. So yes, we do need to figure this out and be open in how we assess for these issues.
Great. Thank you so much. And unfortunately, we're out of time for today. I would love to keep this conversation going and many other really important questions, but I want to thank both of our presenters for their leadership and work in this space and for being here with us today. And thanks also to all of you for joining and asking a lot of great questions. And I hope we are all able to take something away today to bring back to our own work. And there's a link to the evaluation in your web links box on the slide you see, and it should have also popped up in your browser. So we hope you'll give us just a little short glimpse of how you found today's session so we can keep improving them. And with that, we will close out the session. Thank you again to all, and have a wonderful rest of your week.